The challenges were not only taste, which is well recognized, but the fact that the US consumers rely on commercially prepared foods and meals over which they have almost no control of the sodium content. The challenges for the food industry that were salt as well as sodium have useful but not easily replaced functions. The year 2010, I think, reflects a turning point of sorts in that several government agencies asked the Institute of Medicine to develop a report on strategies to reduce sodium intake. That report laid the groundwork for the concept of involving the entire food supply and for the need of leveling the playing field for the food industry. At the same time, the New York City Department of Public Health, along with other groups such as Canada and the United Kingdom, began new approaches to work collaboratively with the food industry. So moving from the past to the present, we currently are at a relatively high sodium intake in the US with recommendations to move down to 2,300 milligrams. We know that more than 70% of the food in the US diet comes from commercially processed and prepared foods. And at the same time, we have science supporting the concept of moving from 34 down to 2,300 milligrams. In 2016, the US Food and Drug Administration undertook an important activity. The agency offered draft guidance for food industry's voluntary reduction of sodium levels in their food. The overall intention was to facilitate a dialogue and begin an extremely slow and deliberative process. The focus is packaged and prepared foods, including those in restaurants. And the approach is to work to establish within a variety of food categories a target average sodium content for the products in that food category. Participation is voluntary, and the assessment will be conducted by monitoring the US food supply for sodium. To give you a sense of a fairly complicated process, what the agency did was identify 150 food categories, and then for each food category, establish a baseline, or if you will, a current estimate of the content of the sodium products in that category. But it was weighted by sales data. Then, using a model, a prediction model, based on national food intake surveys, the agency worked to set a target average sodium content for each category that would support first a reduction for the entire US food supply down to 3,000 milligrams per day for a population average intake, and established that as a 2-year target. It then used the same model to support a reduction down to 2,300 milligrams overall as a population average, and established that as a 10-year target. It also provided an upper bound for each category. So to give you an idea of what this looks like, this is an example of 5 food categories. And if you look down to, let's say the fourth one down, flavored grain chips, you see that the baseline is estimated to be 674 milligrams per 100 grams of food. The 2-year target moves to 590, and the 10-year target to 450. No idea what that is. It's gone. And then there's the upper bound on the right. What in essence is happening here is the 2-year and the 10-year targets are goals to be achieved, and the upper bound reflects a kind of standard over which no manufacturer would want their product to go. In other words, it's the highest level, the suggested highest level. This is a slide taken from the FDA website, and it's intended to illustrate that while there may be challenges, the reductions in some cases may be almost there. This is for the food category, pre-cooked sausage. And in blue, you have the various brands and the sodium content of their pre-cooked sausage. You can see that it varies all the way from down here, about 400 milligrams per 100 grams of food, all the way up to more than 1,400 milligrams per 100 grams of food for the single food product, pre-cooked sausage. The baseline here is in the pink, And you can see that given the 2-year target here in yellow, a number of products have made the 2-year target. And in fact, a number of products have made the long 10-year term product as well. What this also illustrates, however, is that for the same food product, different companies, different brands, different manufacturers are expressing an array of sodium content for exactly the same food. An impressive array, I might add. Now, there are a number of general expectations for the food industry given this voluntary guidance. And the first is to ask themselves as to whether this product exceeds the upper bound, and then to question whether their product can get closer to the draft target and thereby contribute to the average all sodium reduction. The agency did not provide methods or recommendations as to how the industry would accomplish this, arguing that the industry knows best how to do this and is in the best position to create these innovative technologies. But the draft guidance signals repeatedly that the intent here is a dialogue and extremely gradual reduction so as to maintain sustainable overall reductions. Now, the industry did comment on this draft guidance. There were about 200 comments in all. And as you can imagine, they were extremely diverse comments. I think one general theme that emerged was that some of the categories should be adjusted based on the reality of the food categories as experienced by the food industry. And they asked for more information as to how these food categories were established so that they could fine-tune their comments as far as adjusting the categories. Another overarching theme was that the 2-year target was too short. They would like it extended to 4 years to give them time for the innovation and exploration that is needed to create these technologies. They also asked that FDA consider a process to address marketplace shifts. Many comments underscored how complicated the methodological process was, especially the need for new technologies. Such interests were mentioned at that 2015 ILSI workshop on reducing sodium intake in food. And this little table here on the right is taken from the proceedings of that workshop. On the left side of the table, you have the agency's set of activities that are needed in order to reformulate in the case of sodium. And then on the right side are some, but not all, of the challenges that the industry faces in making these reductions. Now, obviously, an important question is, will these reductions to targets have an impact on sodium? And of course, the agency made its model public, and based on its predictions, it will in fact occur. A second set of researchers developed a similar kind of model using very similar food categories and concluded that meaningful reductions could occur with widespread implementation of these targets. Based on the 2-year targets, their model predicted that the overall sodium intake could be in the range of 2,700 milligrams. And the model also predicted that the number of adults exceeding that 2,300 target would be reduced from 88% to 71%. Now, turning to the emerging and at times passionate discussions about the science surrounding sodium reduction, I think a starting point is to acknowledge that we all know that high sodium intake, when reduced, decreases the risk of blood pressure, and that high blood pressure is an accepted predictor of the risk for health outcomes. What's less certain is the direct link between sodium intake and certain measurable heart conditions such as heart disease or diabetes. But what is important is that the major focus is widely accepted that moving from the current 3,400 down to 2,300 is a good thing. Where there is turmoil is the question surrounding the reduction below the 2,300 milligram target. Beginning about 5 to 10 years ago, based on these questions about health outcomes, a number of researchers suggested that a J-shaped risk curve existed for sodium intake, with lower sodium intakes being associated with higher risks of cardiovascular disease. Other researchers have suggested risk with lower intake for certain disease subpopulations, such as those with congestive heart failure. And even other researchers suggested there was a kind of sodium intake set point, a natural level at which appropriate sodium intake existed, and they indicated that this was above 2,000 milligrams per day. So in effect, there's a group who are saying that there's risk in going below the 2,300 milligrams per day. And as you can imagine, this became extremely controversial, with another set of researchers pushing back, arguing that the data were flawed, particularly the ability to measure sodium intake. In part, to help settle some of this controversy, the Centers for Disease Control and Prevention requested a study from the Institute of Medicine focused specifically on this question, the range between 1,500 and 2,300 milligrams. Was it safe and was it efficacious? Their report was issued in 2013, and the conclusion was that the data did not allow the question to be answered. They could neither say there were benefits or harms associated with the 1,500 milligram per level, which means you can't justify a national push down to 1,500 milligrams per day, but you cannot say that there's harm in the 1,500 milligrams per day. They did caveat that a little bit by saying that some of the data suggested that lower sodium intakes among these disease subgroups, such as those with congestive heart failure, may exist, but the data are so uncertain they were not willing to make a strong conclusion. I think what's important for the conversation we're having today about reducing sodium intake is that this committee very strongly underscored the value, the public health value, in moving from the 3,400 down to the 23. Now turning to reference values, which are the next big sodium step in the US. The current reference value, or dietary reference intake, which is used by both the US and Canada, was established in 2005. This year, the Canadian government, as well as the US government, has requested that the group that's replaced the Institute of Medicine at the National Academies convene a committee to review and update the DRI in sodium and potassium as well, because the two are linked. The review is being initiated this fall, and it's expected that the final report will be released at the end of calendar year 2018. To help support this committee's review, the U.S. Agency for Healthcare Research and Quality has been undertaking a systematic review of the sodium and potassium literature. This systematic review is conducted by methodologists who are trained to do unbiased, objective reviews of data quality and to array these data in a fashion that allows a working group to consider the totality of the evidence. I do want to emphasize that a systematic review in no way gives an indication of what could or should be a dietary reference intake, nor does it make any of the decisions that you would expect an IOM DRI committee to make. It's simply a data array, plain and simple. And this from the task for the ARC review is a very complicated slide, but I put it up only for the purposes of indicating that it will include both blood pressure as well as the final health outcomes. It will include benefits as well as adverse effects, and it will include adults as well as children. We are expecting this report literally any minute. It's slightly overdue, and as soon as it's finished, it will be passed through the national academies. And then my last slide here, and it's at risk of overworking an old adage. I will say that those who ignore history are doomed to repeat it. And it seems clear that the U.S. experience of advocating that consumers just say no to salt has not worked. And that's likely a good part of the reason, due to the fact that we don't know that much about salt taste. So I have chosen to put research on salt taste as the absolute top research agenda item from my perspective. Without it, it's difficult to go anywhere. But second to that, simply saying to the food industry, take salt out of your food, has not worked very well either. And so second, I have put the question of better research for reducing salt and sodium in food. And I think a particularly innovative approach is some of the stealth strategies that I'd like to talk about later on in our panel discussion. I don't think we can forget very readily the interface with the consumer. I'm not sure that the messages in the past were wrong, but simply the ability to implement them in the dietary context in which the average U.S. consumer finds him or herself simply wasn't working. So we need to think about new methods and messages in that way. And then, of course, as underscored by the 2013 IOM report, we need to do a lot more work in how we measure sodium intake. And then finally, as you'll hear later in the session today, we need to explore the way in which sodium interacts with other dietary components in the hopes that these types of explorations will provide new and additional ways of addressing the challenges of sodium reduction. So with that as a thank you, I think what we'll do is move to our next speaker, and we'll save some questions for the panel at the end, if that's okay.